welcome to all the faculties and attendees. Today, we are conducting a hematology masterclass whose program chair is none other than Dr. Ashok Vaid, a Padma Shri awardee for his contributions to medicine. He is a chairman in Department of Medical Oncology and Hematology in Medanta the Medicity, Gurugram. I would like to invite Dr. Vaid to give a welcome address. Thank you. Over to you, sir.
Thank you, Priyanshi. And at the very outset, I thank Samarth Life Sciences Private Limited and particularly Om Mishra, who's been driving this initiative. We have had a lot of talks about holding these master classes with the view that we spread it thin, take it to all parts of the country, have faculty from almost every corner of the country get involved in various workshops and these master classes, and also involve as many as possible students, young oncologists, so that the dissemination of information becomes more meaningful. Also, my sincere thanks to the faculty for taking time out, going through all that material which has been presented recently at ASH, and this is largely drawn upon the program of the recently held ASH, and one can see that we have a rich flavor and a spectrum of the hematological malignancies which are being presented and discussed today. A lot of new data, exciting data, new path-breaking and practice-changing data is being discussed today. CML, myeloma, DLBCL, and across the acute and the chronic leukemias. And at the end, we have a take-home message which Dr. Nitin Sood is going to deliver. I'm grateful to Dr. Suman, Dr. Anita, Dr. Deba Dulal, Dr. Ranjit Sahu, Dr. Rakesh, Vikas, Nilesh, all of them for taking time out, and also all the attendees for taking time out, showing their enthusiasm. And I'm being told that we already have 274 registrations for this program, and then we are still counting from many parts of the country and also from abroad. So enjoy the program and the proceedings, and I hope there is learning at the end of the day. With that, I hand over the proceedings back to Priyanshi. Have a very happy New Year and a Merry Christmas to you and all your families. Thank you so much. With thanks and gratitude to everyone who's made this program come alive. Back to Priyanshi.
Thank you so much, Dr. Vaid, for welcoming all the faculty so delightfully. Now let us begin with our first talk, which is on update on CML. And for that, I would like to invite Dr. Suman Mittal. She is consultant in Department of Medical Oncology and Hematology in Mittal Cancer Hospital, Raipur. Ma'am, over to you.
Yeah. Thank you. Thank you, Dr. Vaid, for organizing such program. Thank you, Hari-Om, for being instrumental in organizing such programs, because these kind of things are very important. Because updates, it not only helps we as a consultant to understand what are the recent updates, also the students and newer medical oncologists, and to the students it is very helpful. Because medical oncology is an ever-changing branch. So today we'll be talking about the update on CML. So today I'll be talking about the data of ESMO-4. That is about the drug asciminib, which on addition to imatinib versus imatinib alone or switching to the immunoglobulin. So we'll see the patient with chronic CML who had, and this drug has been used in the patients of chronic myeloid leukemia who did not achieve molecular response after more than 1 year of imatinib therapy. So next slide, please. Yeah. Previous one. Next one. So, as we all understand that life expectancy for patients with chronic myeloid leukemia chronic phase who receives TKI is almost similar to general population, and improving treatment-related quality of life and extending treatment-free interval are our goal. So almost 30 to 60% of the patient with CML-CP receiving first-line therapy with second-generation TKI will not achieve deep molecular response after 5 years of treatment. So that is a big number. And even fewer patients will achieve this response with imatinib. So, and we understand that most of the time in our country, we are using imatinib. So the patient who are achieving deep molecular response with imatinib alone is still less. So now we have a newer drug that is asciminib. And this study is about adding asciminib to patients who have already receiving imatinib but has not received a deep molecular response. So asciminib is basically BCR-ABL inhibitor to specifically targeted ABL myristoyl pocket, that is a stamp. It was first approved in US for adults with Ph positive CML-CP who have been previously treated with more than 2 lines of TKIs, and for Ph positive CML-CP and T315I mutation, and later it has been approved for this treatment worldwide. So currently, this study is phase 2 data. It's the phase 2 trial which reports on the efficacy and safety of addition of asciminib to imatinib, and it has been compared with continued imatinib or switching to the nilotinib in patient with CML-CP who has not achieved deep molecular response with more than 1 year or 1 year of treatment of imatinib therapy. So those are the patients who have not received deep molecular response at the end of 1 year therapy with imatinib. Then these patients were the who have been taken for this study. Next slide, please. So it was an open label randomized multi-center phase 2 study, and inclusion criteria were adults with CML-CP, more than 1 year of treatment with first line imatinib, or those patients who have not received deep molecular response, that is BCR-ABL more than 0.01 but less than 0.2, less than 1%. So it was divided into 5 different subgroups. So the asciminib alone arm has been separated. It has been, data has been analyzed separately. So in this study, these 4 group has been analyzed. So first group is asciminib 40 milligram. That has been added to imatinib 400 milligram. Second group, asciminib 660 milligram added to the imatinib 400 milligram. So these are basically two different doses of asciminib, 40 milligram and 60 milligram. Third group is imatinib uncontinued, and fourth group is where patient has been switched to nilotinib 300 milligram for 300 milligram BD, and then crossovers was allowed between imatinib to asciminib. So, and this primary endpoint was rate of deep molecular response, that molecular response 4.5 at the end of 48 weeks. Next slide, please. So, if we see the baseline characteristic of these patients, so median age, maximum patient had a median age ranging from 20 to 72 years, between 18 to 65 years. Again, maximum number of patients, and patients who have more than 65 years of age, the number were much less as compared to between 18 to 65 years of age. Females, percentage-wise, it was 38, 23, 23 in different subgroups. The median prior duration of imatinib treatment was more than 2 years. So if you see that way, randomization is a balance. So almost equal characteristic. And last but not the least, so these were our study data. So the patient who has not achieved major molecular response. So that is BCR-ABL ratio more than 0.012, less than 1% at the end of 1 year minimum. Next slide, please. So the data was analyzed at the end of 24 weeks and 48 weeks. And our primary endpoint was data analysis at the end of 48 weeks. So if you look at this, so this is the arm with asciminib 40 milligram on top of imatinib, asciminib 60 milligram on the top of imatinib, continued imatinib, and change to nilotinib. Same is the data with 48 weeks. And if you see both the data, the response of adding asciminib to imatinib is much better than imatinib alone or with change to nilotinib. And as we go further, so response is even better at the end of 48 weeks as compared to 24 weeks. Next slide, please. Now, median time to molecular response of deep molecular response 4.5. So if we see that both imatinib, asciminib 60 and 40, both has almost median time to achieve molecular response is almost similar as compared to imatinib, where it took long time to achieve this deep molecular response, and even nilotinib took longer time. So even median time to achieve deep molecular response is much higher with nilotinib alone. So we see that both asciminib 60 milligram or 40 milligram, when we add it to imatinib, it is very effective in achieving major molecular response. Next slide, please. So if we see this data, so this is analysis at 48 weeks. So if we see this, so this is imatinib 40 milligrams. So at the end of 48 weeks, 19% of patients achieved deep molecular response. 28.6% patient with asciminib 60 milligram with imatinib achieved major molecular response. None of the patient with imatinib alone achieved deep molecular response, and 14.3% which switched to nilotinib arm received deep molecular response. So we see that this asciminib is significantly better response-wise at the end of 48 weeks as compared to nilotinib or continued imatinib. And these are the estimated data that the patient who have already achieved response. So whether they are going to maintain this response or not. So this data says that almost this is expected data based on this data. So almost 60% of the patient with 40 milligram asciminib with imatinib will maintain this deep molecular response. 80% of the patient with 60 milligram asciminib with imatinib with maintain deep molecular response in long term, and 66.7% with nilotinib alone will maintain this deep molecular response, which they have already achieved at the end of 48 weeks. Next slide, please. So here our primary endpoint was to look for the deep molecular response, but other than that, this bar diagram also shows that the patient who have not achieved major molecular 4.5, but also there's a sub-analysis of how many patients have received major molecular response 4, right? So if we see this data, this is for asciminib 40 milligram. So 19% of the patient achieved molecular response 4.5, and another 23.9% achieved major molecular response 4.5. So total 42.9% of the patient with asciminib 40 plus imatinib arm achieved major molecular response, including both 4.5. As compared to that, this data shows that 28.6% patient achieved response, major molecular response 4.5 with asciminib 60 milligram on addition to imatinib. None of the patient with imatinib alone arm achieved deep molecular response, and the patient who switched to nilotinib, again deep molecular response of 4.8%. That is a molecular response 4.4. This is 4, and this is 4.5. So total 23.8% of patients received deep molecular response at the end of 48 weeks with nilotinib alone. So this again shows that the patient, when asciminib was added to imatinib, the response rate is much better as compared to continued imatinib or to switching to nilotinib. Next slide, please. So again, this data shows that this is adverse event, serious adverse event leading to discontinuation, and adverse event leading to the adjustment of the drug. So if we see this is about the patient who have received molecular response 4.5, and these are the patient who have received molecular response 4. So if we see that the side effects are much lesser as compared to nilotinib, but it is slightly higher as compared to imatinib alone. So, and if we see analyze this sub data, the patient who have achieved deeper response, that is a response 4. Major molecular response 4.5, they are more likely to have side effects, adverse events, as compared to the patient who have received deep molecular response 4. And that continues not only with adverse event, that also continues with the serious adverse events and leading to the discontinuation and dose adjustment. So what I mean, the patients where the drugs are more effective. So deeper response, more is the side effects. That's what this bar diagram shows. Next slide, please. Next slide, please. Thank you. So these are the adverse events of special interest. So various adverse events has been listed, and number of the patient who had this all grades or more than grade 3, that has been listed. So when I saw this data, so what I find that asciminib on addition to the imatinib is much safer as compared to nilotinib arms in respect almost all major side effects. So next slide, please. So what are the conclusion? That this S4 more phase 2 trial suggests that addition of asciminib to imatinib leads to higher rate of deep molecular response as compared to continuation of imatinib alone or switching to the nilotinib in patient with CML-CP who have not achieved deep molecular response with imatinib therapy alone, who have received it for more than 1 year. Addition of asciminib to imatinib was well tolerated, not associated with new safety signals which was previously reported with asciminib monotherapy. So it is well tolerated, fewer side effects and fewer serious adverse events and discontinuation due to the adverse event with addition to asciminib versus compared to nilotinib. So here we are comparing it with the nilotinib. So once a patient is not responding to imatinib, so what option we are left with to continue with the imatinib, where we see there is not much of the response, or switching to the other molecule like imatinib, or addition of a newer molecule to imatinib. And we see that addition of asciminib to imatinib is not only effective, but it is also very safe from the point of view of adverse event and serious adverse events both. So investigators concluded that addition of asciminib to imatinib may be an important early line of treatment to help patients who have not achieved deep molecular response even after receiving more than 1 year of imatinib, and it achieves quick and deep response as compared to switching therapy. So asciminib monotherapy will determine, we are further waiting about the other trial data, that what is the result of asciminib monotherapy, and asciminib monotherapy arm will determine if monotherapy is as effective as addition of asciminib to imatinib. So we are waiting for the data where we are comparing asciminib monotherapy with asciminib with imatinib. So that data is still pending, and two additional first line monotherapy studies is ongoing, that is as for first and as for start. So that was all about the newer drug asciminib. Thank you.
For giving such an informative talk on CML. So now I would like to invite Thank you so much, Dr. Suman, for giving such an informative talk on CML. So now I would like to invite our next speaker, Dr. Anita Ramesh Chandra. She is a senior consultant and professor and head in Department of Medical Oncology and Pediatric Oncology in Apollo Hospital, Chennai. She is going to speak on myeloma. Over to you, ma'am.
Yes, hello. Very good evening. A very good evening. Can you hear me?
Yes, ma'am, we can hear you.
Yeah, Priyanshi, you will share or you want me to share?
Ma'am, we can share.
Yeah, I'll share. If I am unable to share, you will share for me.
Ma'am, I have
Okay.
already shared.
Okay, I'm doing it. See, it has come.
Yes,
Okay.
ma'am. Yes, ma'am.
Yeah, I think some of these slides are not very proper. Okay. Okay, so yes, a very good evening to everybody, and thanks for inviting me for this particular program. And here we are out here to discuss some of the myeloma updates which has happened so far. And then if you see the latest research in the myeloma and many scientific papers and lot of researchers and a lot of people all over the world are working on the topic of myeloma. So it's a treatment, just to tell a few lines, is a treatment paradigm, and there is involvement of the bone marrow, and we have found new targets, which is the environment is also involved, and a variety of new drugs are already there for the treatment of myeloma. And as you know, all this particular disease relapses quite well, and there's also a drug resistance which develops. So newer drugs for the treatment of the relapses also available for the treatment. Now, coming to the these are some of the updates which are covered. And if you know, some of the B cell mutation antigens is a marker of the cells for the targeted myeloma cells, even antibody drug conjugates with CAR T cells also in the armamentarium of relapsed myelomas. Venetoclax also has been approved and used in a relapse setting. MCL inhibitors are a class of drugs which does destroy myeloma cells, are also in the armamentarium. And even the biphasic T cell engagers, though not updated in India, are some of the researches that is going on for the treatment of these myelomas. Now let's come into some of the drug combination. So it becomes resistant to the standard of care, these myelomas, and they do develop multi-drug resistance. And our commonly used drugs is bortezomib, lendexa is usually used everywhere. Another variants of bortezomib with cyclophosphamide, dexamethasone, carfilzomib, lenalidomide, also ixazomib, lenalidomide is available, carfilzomib, pomalidomide. These are some of the drugs which are already in the armamentarium. Even daratumab, bortezomib, dexamethasone is quite a popular regime. That's what we do use. Coming to the point number, major headings under which myeloma gets treated is the immunotherapy. And this is a type of immunotherapy which is designed to boost the body's environment to fight against. So yes, drugs of the immune mediation like the CAR T cell immune therapy is approved, and it works to treat the cancer, and particularly in case of relapse setting. Immune checkpoint inhibitors like the PD-L1 inhibitors, pembrolizumab is also in the armamentarium for the treatment in the current researches, and showed some benefit in the treatment of myeloma. Yes, cancer vaccine all around for a long time, but yet to make a footing. Apart from this, palliative care. So those are the big 4 points by which myeloma has been treated all over, and that's one of the updates that I thought that can be brought. Yes, another thing is what you look for the minimal residual disease, and over here in the screen, what it shows is the GEMSSR, where you have a sustained minimal residual disease. That's 4 years after the treatment with the autologous stem cell transplant with high-risk smoldering myelomas. So that's the phase 2 study where the GEMS is our study design. Carfilzomib was used, and carfilzomib is now easily available in India, and many of us are using already. It is used twice in a week, every week for the first 3 weeks, along with lenalidomide and dexamethasone, and then we go for the transplant after this drug is given, and thereafter the carfilzomib lenalidomide is continued. Okay, and we continue maintenance of the lendexa. So if you see the patient characteristics, they are definitely elderly patients, and some were high risk definition as per the Mayo Clinic model, and there were ultra high risks, and there were patients with cytogenetic different abnormalities included in the study. And the ultra high risks were those which had the flow cytometry ratio serum FLC of greater than 100, more than one focal lesion in the MRI, and greater than 60% of plasma in the bone marrow. Okay, fine. Next is coming to the response rate. Okay, as the response rate showing the with the induction, with the high dose, and the consolidation and the maintenance dose. And if you see the MRD negative, it was 40% as shown after induction, and it increased after the high dose and with the maintenance. Okay, in this study, the undetectable MRD at 3 months and 4 years after the autologous stem cell transplant was as shown over here, ranges between 68 and 43%. Now, coming to the biochemical progression, there was definitely a decrease in the level of the plasma cells or the myeloma cells. There was a biochemical decrease immediately after the over a period of time after the treatment. Then some of the important factors predicting the biochemical progression is the how many modes of the therapy and how many times these patients has been progressed, and how many what are the different aspects of the disease, and whether the previous transplant has taken place or not are some of the important risk stratification. And if you see the other risk stratification, that deletion 17p, translocation 414, 416, 420, gain of 1q, and p53 mutations are all considered as high risk for myeloma. And if you have more than 2 factors or high risk factors, which is considered the double hit myeloma, or 3, which is called a triple hit myeloma, and these are one of the factors which leads you to the very poor prognosis. And these risk-adapted initial therapies are the ones, if you have these high risk factors, then you go for the autologous stem cell transplant. Usually the induction takes place with bortezomib and dexa, okay, and 3 to 4 cycles, then as the patient gets prepared for the autologous stem cell transplant. And in the high risk individuals, I have already alluded the drugs daratumab, dara, VRT, or bortezomib blend dexa is also an alternative to bortezomib. And these selected standard risk people are also exposed, which are having the high risk factors. And if you're not planning for transplant, whatever the reason is, 8 to 12 cycles followed by maintenance of daratumab, blend, dexa until progression is a good option for them. And as you have seen previously, the maintenance therapy also is the standard risk needs just lendexa maintenance, whereas bortezomib blend we added to the high risk myeloma, and you continue standard risks. In my clinical practice, I have continued standard risks up to maybe more than 2 to 3 years before you get them relapsed. Yes, management of the triple is the relapsed is what we are now looking at, and then usually that becomes very difficult, and a triple drug is what is needed. And these are some of the factors and the high risk things which helps you predicting progression to an active disease. Like I told you, the bad prognostic translocations already treated or not, or the comorbid factors. Okay. There is also an overall survival benefit in the GEM-CSR protocol, which you see. And then even with the investigators' chosen drugs, this has shown to be much more effective. Now, let's move into the other study, which is the ACCENT, which is the phase 2 fixed duration therapy with daratumumab, carfilzomib, lenalidomide, and dexamethasone high-risk smoldering multiple myeloma. This smoldering multiple myeloma is one that needs to be also diagnosed properly, and it is in the initial stage. And this smoldering myeloma, which is also just comes before the MGUS, which is the pre-malignant condition, monoclonal gammopathy of undetermined significance. And sometimes this progress into smoldering, so there's a little bit gray zone between which we need to really identify these cases. Now, if you see the ACCENT study, again, what they used was carfilzomib, lenalidomide, okay, and daratumumab weekly for 8 weeks, and dexamethasone. The dose is the standard dose, carfilzomib 26 milligram per square meter twice weekly, and lenalidomide 25 milligram per daily for up to 21 days, daratumumab weekly for 8 weeks, and dexamethasone. And then followed by consolidation of carfilzomib, len, daratumumab once in 4 weeks, and dexa. So daratumumab and carfilzomib is quite a good drug, and yes, one has to be. I have used a couple of patients on these drugs, relatively safer, but one should be quite careful to give the manage the. Daratumumab does have an initial IV line toxicity, but overall it's a safe drug. And so it was the maintenance therapy continued 12 or 4 weekly cycles with lendexa, and the MRD was reported negative by flow cytometry and measuring the overall survival, progression-free survival, safety, and toxicities. Again, baseline remains the same. Then the IMWG, that is the risk stratification model, was used, and M spike greater than 2 grams, the FLC ratio greater than 20, and bone marrow plasma cells greater than 20%. Yes, the beta-2 microglobulin LDH were also taken into consideration. That's the survival curve, almost flattening with the use of this induction, consolidation, and maintenance. Yes, adverse reactions. So these are several newer drugs which are coming into the use of these use of the myeloma by to improve the prognosis. And as you know, it's a chronic disease and cannot be cured. But definitely side effect toxicities are there, which will be almost similar, or some differences will be there. And hematological toxicity, yes, 18% patients had, and non-hematological toxicity grade 3 was around 50%. Yes, we did need a dose reduction of carfilzomib, lenalidomide, and dexa in some cases. Median dose is 1,600 for daratumumab and carfilzomib. And in our Indian context, we do go with a little lesser dose. We don't go up, and at least in my practice, we will be going up with the lesser dose. So the conclusion of the study, it's a well-sustained, it's a well-tolerated regime to be given at higher centers. Yes, it does give you a considerable sustained response. Now, coming to the another study, DSMM-13 is again induction followed by autologous stem cell transplant, followed by maintenance in these particularly elderly, newly diagnosed above the age of 60. So as you know, this is a very, very vulnerable people set of subsets, and giving a high dose stem cell and maintenance is quite a difficult things, and the baseline remained the same. And the adverse reaction, yes, people did have progressive disease was seen, and withdrawal. And if you see the overall response rate, which is taken as the best complete remission, the very good partial response taken together, it was 89% compared to RD, which was 87%. Small percentage difference was seen. And that was the progression-free survival. Some small change in the dose, the graphs were seen. Okay. Okay, if you see by the age, yes, age does matter, but then it's not a remarkable difference between the progression-free survival. Even the overall survival data did overlap with each other. In a transplant situation, yes, the progression-free survival and then the overall survival was relatively much better. The incidence of the second malignancies, primary malignancies, yes, skin and solid tumor hematological was noted. I think if you see both the charts taken together, it was more in the RD compared to this. So again, this is not a point to mention to say these are some of the very important points for differentiation. So phase 2, another study, I did gene in patients with myeloma when you have an early relapse after the stem cell transplant, and then you do leukapheresis, cyclophosphamide, and the drug Captogene is newly used, not available in India. And as I mentioned earlier in my talk, CAR T cells is coming into the treatment, and to see which best patients can be best treated. Cohort of the patient remains the same. Overall response rate was in 83%, but I think it is too early for us. Median overall survival was not met, and median progression-free survival was hovering around in a year, and the best duration of response is 15 months. So again, this is another study where the CAR T kinetics was seen, and many of the studies are now bringing into CAR T cells, so availability is difficult in India, but yes, over a period of time when we are able to make more of these cells much available in India, we should be able to give many of our patients, okay, by these things. So just concluding, so if you have a smoldering high-risk myeloma, or you have a newly diagnosed myeloma or an elderly myeloma, the survival has improved over the period of time, over the last 15 years. The initial impact of induction with thalidomide, bortezomib, lenalidomide has now brought into carfilzomib, pomalidomide, daratumab, okay, ixazomib, into the armamentarium, and even the CAR cell T cells, though not easily available in India, yes, is moving forward. The FDA has approved many of these drugs for the relapsed and in the first line as well. So there is a lot of other studies, newer receptors are being found out to see how to make this chronic disease a curable condition. So this anti-angiogenic immunomodulatory B cell targeting drugs have, along with the B cell maturation arresting drugs, have improved the picture of multiple myeloma as of today. So yes, some of these regimes are yet to be confirmed, but then this gives us a picture. Yes, when you have a high-risk myeloma, go for induction, go for the autologous stem cell transplant, go for consolidation followed by maintenance. And if it is very high risk, yes, triple drug like bortezomib, lendexa, or daratumide, lendexa, daratumide, bortezomib can be started upfront to give the best results. Yes, elderly patients does have difficult to treat, but then there are regimes available, which is there. And I think with this, we will take a break, and if any questions are there, would be happy to take the questions for a further discussion. Thank you very much. Thanks to the organizers and Dr. Ashok Ved. After a long time, we have got connected. Thank you so much.
It was so nice presentation, ma'am. Thank you so much for that. And with this, we'll move on to our next topic. And for that, I would like to invite Dr. Deba Dulal Biswal. He's consultant in Department of Medical Oncology, Ram Krishna Care Hospital in Raipur, and he's going to speak on update on DLBCL. Thank you, and over to you, sir.
Good evening. Can I see my slides?
Yes, sir. We'll present it.
So my topic is regarding MRD, minimal residual disease, and we have been using it in liquid malignancies like ALL and to some extent in AML. And that is still controversial and under research. But there is a company, this company is called Foresight Diagnostic. They have made a patented thing that is phased SEQ, phase ED SEQ, that is patented. And they are trying it in solid malignancies as well as lymphomas. So my topic is regarding this presentation in AS 2022 regarding DLBCL and its use. So this phased sequence enhances the specificity by requiring the concordant detection of two or more distinct mutations within a single DNA molecule. So what we, next slide please. Next slide. So the topic is phased sequence MRD negative assessment in DLBCL, and the background is current approach to monitor for relapse in patients in DLBCL is by using PET-CT scan or radiograph. This imaging lacks insight into molecular disease burden. So uh, uh, by this technique, we can find out the circulating tumor cell-free DNA surveillance. And so this Foresight Diagnostic, what they have made, they have been able to find out 1 in 1 million particle of this defective DNA molecules, so that they can detect the cancer relapse up to 200 days earlier than other commercially available ctDNA detection methods. So this is an advance in recent time that previously other conventionally used detection techniques of ctDNA is 1 in 10,000. So this, what this Foresight did was they were able to find out 1 in 1 million. So by that, their detection ability has increased, and thereby they can find out really minimal residual disease at a earlier date, that is around 200 days earlier than other things. So previously available methods have been able to, so this is a plasma derived circulating cell-free tumor cell DNA. So phased variant is so I just said that the concordant detection of two or more distinct mutations in a single DNA molecule. So they will try to find out that whether this DNA is still persisting after first cycle of chemotherapy, after second cycle of chemotherapy, after third cycle of chemotherapy, or end of therapy, like that. So they did a serial sequential detection of ctDNA of this phased variant. Means the particular patient will have a phased variant, and that will be detected in a ctDNA method, and that will be done every cycle or every 2 cycle, and at the end of the cycle. And thereby they will, if the MRD is positive, then they will be able to say that yes, there is a molecular disease burden is still there. If it is negative, then they will say that see, the treatment is so good that only after first cycle it has gone, or second cycle it has gone, so thereby it's a good prognostic. Next slide please. So they did so this particular method was done in 5 types of patient varieties. So there were, these details are written like there were total of 112 patients, 290 specimens in a 5 prospective frontline large B-cell lymphoma trials. and this was like R-CHOP or Arda-IPO plus acalabrutinib, or they did with lenalidomide, obisutuzumab plus CHOP, or polatuzumab vedotin with Arda-IPO minus this oncovenizine, and tafasitamab plus minus lenalidomide and R-CHOP. Study objective was to assess progression-free survival, prognostic value of ctDNA status taken during the therapy and at the end of the therapy, analyzed by phased sequence at two different sites. This phase ED sequence is a patented thing of this 4-site diagnostic, so they are using it. Next, current approach is to monitor for relapse in patients with DLBCL using. No, next slide, please. Next slide. This is previous slide. Please go to next slide. Am I audible, Priyansi? Yes, yes. So this was the patient characteristic baselines. They were well matched. Females were around 39%. Median age was, this is between 20 to 85. Median age is 61%. IPI score were well balanced between 0 to 1, 2, 3, and 4 to 5. Stages were 3 to 4, third or fourth stage were of 72%, and first and second stages were between 26%. Study types were mostly DLBCL, around 80 patients, and and PMBCL, and all other similar B cell lymphomas. Next slide. So phased sequence MRD negative assessment in DLBCL, ctDNA dynamics during therapy. So what did they did? They took N was 80, so they did on psych. They were total of 112 patients were evaluable for phase variants. So this phase variant is found in DNA, and that is detected by this phased sequence technology. So 109 patients, 97% were successfully underwent genotyping for plasma or tumor tissue. Rate of MRD negative increased with time in patients without PFS events. So 24% at the beginning of cycle 2, 64% patients were MRD negative at the beginning of cycle 3 and cycle 4, and 91% of patients at the end of treatment. That means around 9% of patients were still MRD positive at the end of treatment. Next slide. So phased sequence MRD negative assessment in DLBCL, sensitivity of MRD detection, PFS prognosis. On treatment and end of treatment, MRD positive disease detection by phase sequence was strongly associated with outcome, poor outcomes. Undetectable ctDNA within 3 cycles strongly prognosticated the PFS. That was HR hazard ratio was 8.1, whereas persistent ctDNA MRD positive at end of treatment, those were high risk group, HR was 84. So MRD positive at end of treatment, 94% sensitivity for PFS events. If MRD is positive, so there is likely in 94% of patients that the disease is coming back. With a median follow-up of 17 months, range is 0 to 64 months, 99% patients with MRD negative at end of treatment remained free of disease progression. ctDNA detection strongly associated with outcomes in multivariate model for in clinical outcomes and testing sites. ctDNA detection below 0.01% threshold was critical for high sensitivity of MRD, and of patients with progressive disease or death, 17% during treatment and 35% at end of treatment had ctDNA level detected below 0.01 threshold. End of treatment phased sequence and PET were prognostic of PFS, but phased sequence was more sensitive. So that means sometimes the PET CT may be negative, but phage sequence was still showing MRD positive. So that's why phage sequence MRD is more sensitive than PET scan. Next slide, please. This is the conclusion of the investigators. It says that patients with DLBCL phased sequence ctDNA assessment was strongly prognostic of outcomes, strongest predictive value observed for MRD status at end of therapy. You can use the post 3 cycles or end of treatment, but if MRD positive at end of treatment is there, then it is a strongly predictive value for a less PFS. A 1 in 10 to the power minus 6 limit of detection of MRD negativity at end of treatment was critical for assay reliability. So at the beginning, I said that this patented technology, they could be able to find out 1 in 1 million particle, thereby making this technology as a super sensitive assay, and it is reliable. MRD detection at end of treatment has potential role as surrogate endpoint within clinical trials and may, so this is still in clinical trials, but this may come into open market. Investigators concluded that prospective collection of plasma at baseline during treatment and at end of treatment is warranted in clinical trials of DLBCL to assess for MRD. Thank you. Priyanshi, over to you. Thank you.
Great presentation on DLBCL, sir. Thank you so much for that. And now let's move on to our next talk. And for that, I would like to invite Dr. Ranjit Sahu. He is additional professor in Department of Medical Oncology in AIMS Delhi, and he's going to speak on update on MDS and MPNs. Thank you, and over to you, sir.
Hi, good evening. Are my slides visible?
Yes, sir, it is visible.
Yeah. Thank you for this kind invite. And my topic is what's new in MDS MPN in ASH. I do not have any conflicts to disclose. And in brief, these are the prominent abstracts which have been there in ASH 2022. One is this momentum study, which is abstract 627. It is a randomized phase 3 study. It presented the updated results about momelotinib, which is a JAK inhibitor, versus danazol in patients who have symptomatic myelofibrosis with predominant manifestation as anemia. Then the next study was in MPN was the use of interferon alpha 2b, and it was in the pre-fibrotic primary myelofibrosis. This is an important area, an upcoming area, because in primary myelofibrosis, so what we have been concentrating on, the intermediate to and high risk myelofibrosis. But this is the population now they are targeting, that those patients who present with, those who are diagnosed with pre-fibrotic myelofibrosis. This is an important area of research, because in this window, if we treat these patients, we might actually arrest the next stage, which is primary myelofibrosis, which has got a lot of disease burden. Now, the third abstract, which was of interest in MPN, was the analysis of the molecular responses to JAK inhibitor. Now, this had been a good area of focus. And in this abstract, they have shown that those patients who had molecular responses to the usage of JAK inhibitor, which is ruxolitinib, they have a better symptom relievement. And this is in contrast to the previous study, I mean, some previous experiences with interferon, where the molecular responses were actually not much corroborating with the symptom recovery. In MDS, I mean, there was more to understand here. I mean, this is a very interesting abstract, and they looked into 2022 WHO and international systems for genetic and morphologic MDS classification. This was very interesting, and there is a calculator as well. And then this is another study where they have looked into sabatolimab with hypomethylating agent versus placebo. This is a phase 2 randomized study. This was not a positive study. I'll be coming in detail about it. And then this study was the last one looked into the use of low-dose lenalidomide in deletion 5q low risk MDS who are still not transfusion dependent. So let's go with the first one, that is the low-dose lenalidomide versus placebo in non-transfusion dependent patients with low risk deletion 5q MDS. We can skip this background because lenalidomide has been a standard of care for patients who have deletion 5q31 MDS and requiring transfusion. It can reduce the transfusion burden in this patient and can also produce some cytogenetic responses in close to 50% of patients. Now, this study is different. This is patients who have low risk MDS. Still not, they are not transfusion independent. They have been randomized between usage of lenalidomide 5 milligram per day continuous versus placebo. And the primary endpoint was the time to transfusion dependence. These are the usual picture, and they are more common in females, present at a later age group at somewhere around 70s. And this is at a median follow-up of 5 years. Now, in the lenalidomide arm, the median time to transfusion dependence, it has not been reached in that at a 5-year follow-up. While in the placebo arm, these patients who are not transfusion dependent, they are becoming transfusion dependent at a median time of close to 1 year, that is 11.6 months. And the other important part of lenalidomide in myelodysplastic syndrome and overall is lenalidomide can actually promote this TP53 mutated AML, at least in myeloma and some other malignancies. But in this deletion 5q MDS, its relation with those patients who have got co-mutation of TP53, there are some reduction in responses, but they are still responding. And there is no increased risk of developing, TP53 mutated AML at a later time point. So the interpretation of lenalidomide in MDS, in 5q MDS, it requires some more refinement, and I feel that there should be more follow-up to this interpretation. The safety analysis, the predominant toxicity as GI and investigators' conclusion. So it could be a useful way of using lenalidomide in these patients. Now let's come to the next phase 2 randomized study. And in the previous single arm studies, there had been a lot of discussion about using this TIM3 inhibitor, which is expressed on the leukemic stem cells. So there could be more responses in patients who have MDS. This is a phase 2 randomized study with a placebo control, and the hypomethylating agent could be either destabine or azacitidine. As you could see, azacitidine is the more preferred HMA used here. And these are the molecular profiles, and these are the patient profiles. Now, when you look into the complete remission rates, with only hypomethylating agent, it is close to 18%. The median PFS is 8.5 months as compared to the usage of Sabatoli. It is the CR rates are not different. The median PFS could be little, there is some sort of trend. So it didn't meet the primary endpoints. And this is a pretty much fairly well-tolerated drug with no excess safety concerns. So these are the investigators' conclusions, but this is a purely negative study. This the further follow-ups of this study with regard to the subgroup analysis and everything should be looked in carefully. This could be a useful drug in a very subset of patients who do not have a lot of blasts. So now let's come to the third and the last one. Now, this had been an Achilles heel in managing patients of primary myelofibrosis who present with anemia. The only drug that is available to us is ruxolitinib and other supportive cares. But ruxolitinib doesn't improve that much the anemia-related issues. And in a substantial amount of patient, it might actually exacerbate the anemia. And as we know that anemia in primary myelofibrosis is because of ACVR1, which is in excess that is causing anemia. I won't go into detail. Now, this drug momelotinib is a JAK inhibitor. In addition, it is an ACVR1 inhibitor. So this is the study. It has got an interesting study design. Now, this had been a double-blind treatment of momelotinib plus placebo versus placebo and danazol till week 24. And beyond week 24, it is an open-label crossover to momelotinib at the specified doses, which is 200 milligram over day. The primary endpoint in this study, I mean, in any primary myelofibrosis study as of today, is the total system score. And if it is more than, I mean, at week 24, and the primary endpoint is more than 50% reduction from the baseline. This is not a very robust primary endpoint, but as we know, in all the retrospective analysis, this was found to be a good surrogate for having a good quality of life impact in primary myelofibrosis patients. So these are the patient characteristics. They are the usual one. And this is the outcome. If you could see the TSS response at week 24, it is seen in 25% of patients on momelotinib, and on danazol, it is close to 10%. So it is clearly superior. The outcome at week 48, when many of these patients are crossover to the open label use of momelotinib, the TSS response is maintained in close to 100% of patients who are on momelotinib. When they are, and those patients who are shifted from danazol to momelotinib, it is also close to 100%. So this is a positive study, and these are the safety concerns, which is pretty much consistent. And there are no excess safety concerns in these patients. But you should also see that the incidence of COVID-19, it is actually increased in patients who are on a JAK inhibitor. And this is the data of patients who are anemic as well as with thrombocytopenia. So it appears that it is also active in this population with respect to the overall survival and the TSS50 response. So the investigator's conclusion, if I may jot it down briefly, that this could be a good drug in patients of primary myelofibrosis who are anemic and post-treatment with a JAK inhibitor. So momelotinib could be a wise choice in these patients. And with respect to danazol, it might actually produce some better responses with respect to the symptoms as well as anemia control in a subset. And I presume that this is a positive study, and this drug might get approved in the next year or so. So the take home from the MDS MPN abstracts which were presented in ASH 2020 is they are mostly promising. Promising is a very difficult word to understand. Promising is mainly used for agents who are not very successful. They are only modest. So in the abstract, I found that there is more to understand than actually treating these patients. The success had been momelotinib and lenalidomide, which might get approved for these indications in the next year. And sabotilmab, I feel it is a little promising, and it can find a place in patients who have MDS with less number of blasts, but we require to get a study done on this. That was my last word. I'll be happy to answer a few questions if anyone has.
So we will take the questions after the session, like all the session gets over. And it was a very great and explanatory presentation given on MDS and MPN's bio. Thank you so much for that. And now with this, let us move on to our next talk, which is on update on AML. And for that, I would like to invite Dr. Rakesh Pinanti. He is consultant in Department of Medical Oncology in Indo-American Cancer Hospital and Research Institute in Hyderabad. Thank you, and over to you, sir.
Hi, good evening to all. Thank you, organizers, for this opportunity. So I will share my slides. They are visible, right?
Yes, sir, it is visible.
Yeah. So thank you for the opportunity. So I'm going to review some of the one of the update that has been presented in the recently concluded ASH 2022. So this is the COMET 001 phase 2 trial. So COMET full form is basically Curo Oncology menin inhibitor trial. So this is the first in human study of ziftomenib, which is a novel KMT2A and menin interaction inhibitor. This was tested in the relapsed refractory AML. So coming to the biological rationale and background of the study, the histone lysine N-methyltransferase 2A, which is basically KMT2A, or multilineage leukemia rearrangements. These are commonly seen in AML at around 5 to 10% of the patients, and NPM1 mutations are seen in nearly about 30% of the patients. And these are basically the central regulators of the target genes that drive leukogenic transformation. And KMT2A rearrangements and NPM1, these are the founding agents in the leukemia. And basically, the KMT2A rearrangements in AML patients function as a protein complex. This requires menin to cause epigenetic dysregulation in AML, and it also cooperates with the NPM1 to cause dysregulation of the overlapping set of leukemigenic genes dependent on this interaction. So there is a strong rationale for targeting the menin in the KMT2A NPM1 AML. And other things that actually I want to highlight is that there is no targeted treatment that can be utilized to treat these patients with AML in the upfront setting as well as in the relapsed refractory setting. Coming to the overall prognosis, the KMT2A rearranged AML has a very dismal prognosis of 5-year overall survival of less than 20%. So ziftomenib, this is a novel inhibitor that is known to inhibit this KMT2A menin interaction. This has been previously shown to have effect in the laboratory studies, and this is the current phase 1A and phase 1B analysis reporting the safety, efficacy, as well as the phase 2 dose finding analysis of ziftomenib in the relapsed refractory AML patients. So this is a study design. It's an open label first in human study, phase 1, phase 2 dose escalation, validation, and expansion study. And the current analysis, which was present in the ASH 2022, is limited to the phase 1A and phase 1B with a data cutoff point of October 24, 2022. So we have adult patients, relapsed refractory AML. In total, 60 patients were selected. And the phase 1A dose escalation, it was in the all comers. Patients were not differentiated based upon their genetic subgrouping. This ziftomenib was given once daily dosing of 28-day cycle, 50 mg to 1000 mg. And primary endpoint of phase 1A trial was the maximum tolerable dose, and phase 2 dose finding, basically recommended phase 2 dose finding. And secondary endpoints were safety, PK/PD data, and anti-tumor activity. And phase 1B was a dose validation and expansion study in specifically KMT2A rearranged and NPM1 mutated AML patients. For the cohort 1, the dose was selected as 200 mg, and cohort 2 dose was 600 mg. In total, 24 patients were included. And again, the primary endpoint of the phase 1B study was safety and minimal effective dose. And the secondary endpoint was anti-tumor activity, transfusion independence, recurrence-free survival, and overall survival. So these are the baseline characteristics in the phase 1A cohort. Basically, it included patients who were having median age of nearly 65 years of age, a fairly elderly population. And what the point to be noted is that these are the patients who are heavily pretreated. Nearly 3.5 median number of prior therapies these patients have undergone, and a significant majority of the patients have also been exposed to venetoclax. And at least 1/4 of the patients have at least one or two more than one stem cell transplantations. And also, mind you, these patients are having a very preserved performance status despite having nearly 3.5 million prior number of therapies. So this is not a routine, walk-in patient who come into the AML clinic who has previously taken prior treatment. But for the clinical trials and for the phase 1 trial, this is fairly well accepted. So coming to the phase 1A safety data, we can see several the dose level of mg, there is one toxicity with pneumonia. 100 mg, there was one toxicity with neutropenia. As we increase the dosing, there is more cytopenias that are coming up, but none of the cytopenias were actually dose limiting at 200 mg. At 400 mg, there were cytopenias, but there was one dose toxicity, dose limiting toxicities of pneumonitis and post-aspiration syndrome. And there was one patient who was enrolled in the 1000 mg, and he or she developed the differentiation syndrome. And subsequently, there was no further escalation of the dose, and the protocol de-escalated to 800 mg. Again, there was no treatment-related QTc prolongation, and this drug was previously shown in the animal studies as well as the laboratory studies to be not inducing the QTc prolongation. So coming to the phase 1A anti-tumor activity, which was also one of the primary endpoint, we can see that there are at least 2 CR or near CR in those patients who are having NPM1 mutation, and this was noted at the dose level of 100 mg itself. And there is one more patient who had a CR, and this patient was having RUNX mutations. Again, there were at least disease stabilization and transfusion independence in 3 patients who have taken the drug and having the KMT2A rearrangements, and making nearly about 70% of the patients having disease stabilization with the use of this drug in those patients who are having non-KTM1 rearrangement and non-NPM1 mutations. So this is the phase 1B validation study that included 2 dose levels of ziftomenib at 200 mg and 600 mg. 17 patients were delivered 200 mg and 36 patients were delivered 600 mg. As you can see, the median age of these patients is at least 2 decades earlier than the phase 1A trial. It is 49 and 54.5. However, these patients are again very heavily pretreated. The median number of therapies were 3 again in both the subgroups, and significant majority of these patients were exposed to venetoclax. If you look at the differentiation of KMT2 arrangement and NPM1, nearly 70% of the patients in the cohort 1 with 200 mg and 45% of the patients in the cohort 2 of 600 mg were having KMT2A rearrangements. So this is the on-target effect of the differentiation at 200 mg dose level. None of the patients in the NPM1 mutated cohort had any differentiation. Even in the 600 mg dosing, only about 20-25% of the patients developed differentiation. However, in the KMT2A rearrangement, we can see that nearly 40% of the patients, 30 to 40% of the patients at those levels of 200 mg had developed differentiation syndrome. And again, at 600 mg, nearly about 25 to 40% of the patients did develop differentiation after the use of ziftomenib. The reasoning that was given by the investigators is that the KMT2A patients had a lot more extramedullary disease, and because of the good tissue penetration of this drug ziftomenib, there appears to be a lot of differentiation syndrome that precluded a prolonged use of this drug. However, the overall response rates in patients with differentiation syndrome at 600 mg ziftomenib was higher at 75% in NPM1 mutation population compared to only 16% in KMT2A rearrangements. So this is again phase 1B anti-tumor activity. The CR rates were noted in nearly 30% of the patients at dose level of 600 mg compared to only 17% of the patient in 200 mg. Again, MRD negativity in those patients who are in complete response was 100% in those patients with ziftomenib 200 mg. Again, because of these all responses are noted in NPM1 mutation patient, and because this KMT2A rearrangement had a lot of differentiation, none of the patients had actually had any CR rates with 200 mg, and about 5% of patients had CR rates in the ziftomenib 600 mg cohort. This is again represented here again at the CR rates of 30% in those patients who are having NPM1 mutations compared to 0% in those patients who are having KMT2A rearrangements. Coming to disease stabilization, nearly 43% of the patients with KMT2A had disease stabilization compared to that of around 35% in the NPM1 mutation. So coming to the patient disposition, we can see that nearly 27% of the patient continue to be on treatment at the end of data cutoff of October 27, 2022. Again, 70% of the patients are still alive on under follow-up, making it 50% of the patients who are on the dose level of 600 mg continue to have some amount of response. Mind you, these are the relapse refractory multiply treated patients, and treatment discontinuation because of the adverse effects is seen in nearly about 10% of the patients, making that the patient these drugs are quite well tolerated in those patients who can actually avoid the differentiation syndrome. So this is in brief the conclusions of the investigators. It reports a manageable safety and preliminary efficacy of ziftomenib in the relapsed refractory AML. There was no QT prolongation, and on-target differentiation syndrome was considered clinically manageable by the investigators. Ziftomenib 600 mg appears to be optimal dose with clinical activity, and probably a favorable benefit-risk ratio is seen in NPM1 mutated AML patients with a CR rates of nearly 30% in 20 patients. And investigators went on to say that a combination strategy with chemotherapy with ziftomenib can decrease the chance of differentiation syndrome, and actually we can utilize this drug in combination with chemotherapy, particularly in those patients with KMT2A rearrangement AML. So that will conclude my brief discussion on the AML update. Thank you very much.
It was a very prominent and instructive session on EML by Dr. Rakesh. Thank you so much, Doctor, for that. And with this, we'll move on to our next topic. And for that, I would like to invite Dr. Vikas Goyal. He's consultant in Department of Hematology and BMT in SCCH Unit 2, Raipur, and he's going to speak on update on ALL. Thank you. Over to you, sir.
Thank you, organizers, for inviting me for a wonderful CME. So today I will be talking about ECOG ACRIN E1910 phase 3 study. Phase 3 study of consolidation chemotherapy plus minus blinatumomab in MRD negative, BCR-ABL1 negative, B cell ALL. Background, the patient background taken was adults with newly diagnosed ALL who achieve CR with conventional chemotherapy often relapse, even if MRD is negative after induction. So this leads to suboptimal survival outcomes. What is blinatumomab? It is a bispecific T-cell engager that binds to both CD19 and CD3. FDA has approved for this agent for treatment of CD19 plus BALL in first or second CR with MRD of equal or more than 0.1% and for the treatment of relapsed refractory CD19 plus BALL. And the mentioned phase 3 trial investigated consolidation chemotherapy plus minus blinatumomab to determine if addition of blinatumomab improved outcomes for patients who become MRD negative, that is less than 0.01% after induction chemotherapy. And current analysis reflects median follow-up of 3.6 years, that is 43 months. This is the study design. Here we can see that it is a multi-center randomized open label phase 3 trial. Patients aged between 30 to 70 years with newly diagnosed Ph negative BLL were taken. Total number of patients were 488. Induction was given by BFM type regimen. And those patients who came into CR or CRI, intensification was done with high dose MTX plus PEG L-asparagine. And then depending on the MRD negative positive, consolidation therapy were divided into two parts. One is blinatumomab plus chemotherapy. Total number of patients 112, and another arm took only chemotherapy. Patient number 112, and maintenance was as standard per oral 6 MP tablets. Primary endpoints were was overall survival in MRD negative patients, and key secondary endpoints were MRD status, relapse-free survival. These were the patient characteristics. Post-induction CR/CRI rate were 81%, 395 out of 488. CR rate 75%, and CRI rate were 6%. And MRD status after intensification, MRD negative 78%, and MRD positive 22%. At third interim analysis, 80% of patients assigned to experimental arm received equal or more than 2 cycles of blinatumomab. In the tabulated form, you can see the median age was 51 years, and the MRD patient who proceeded to stem cell transplantation were 22, and MRD positive patient 40 and 22. This is a graph showing survival in MRD negative disease. You can see that overall survival in MRD negative disease. You can see that those patients who received blinatumomab plus chemotherapy, their overall survival was much better than as compared to patient who received only chemotherapy in the consolidation. In the tabulated form, you can also see that the combination regime were having 3.6 year overall survival 83%, as compared to only 65% who received only chemotherapy. Deaths were considerably less in combination therapy, 17, as compared to chemotherapy, 39. At third interim efficacy analysis, ECOG, ACRI, and DSMB recommended releasing results due to benefit observed with blinatumomab in MRD negative disease. Overall survival in MRD positive disease, you can see the efficacy outcome, median overall survival in combination arm not reached. In chemotherapy arm, it is 22.4%. Deaths were 9 in combination arm, while deaths were 13 in the chemotherapy arm. So this agent not only demonstrated benefit in MRD negative patient, but also this agent has shown benefit in MRD positive patients. So these were the investigators' conclusions. Result from this randomized phase 3 trial demonstrated significant overall survival benefit with addition of blinatumomab to chemotherapy as consolidation therapy in adult patients who are MRD negative, BCR-ABL1 negative BLL. Blinatumomab plus chemotherapy was well tolerated and it showed no new safety signals were observed. So investigators concluded that addition of blinatumomab to consolidation chemotherapy represents new standard of care for patients with MRD negative, BCR-ABL1 negative B-cell ALL. Thank you.
A very accurate and satisfying talk given by Dr. Vikas on ALL. Thank you so much, Doctor, for a great talk. With this, we are coming to our last session of the day. And for that, I would like to invite Dr. Nilesh Vasekar. He is hematologist and BMT physician, HSCT unit, Nasik Hematology Services, Medicover Hospital, Nasik. And he's going to speak on update on CLL. Thank you and over to you, sir. So you are on mute.
Thank you, Dr. Priyanshi, for that introduction. And I think this is my last session, and I'll try to finish it as early as possible. Okay.
No, sir, you can take time.
Yeah.
It is okay.
So can you see my screen?
Yes, sir, it is visible.
Okay. So I'm going to talk about CLL update in 2020, and there is a lot of exciting data which has come up in a recent ASH meeting, as well as very good publications recently in the management of CLL are recently published. So I'm going to discuss about two trials in our meeting. So first one is Alpine trial, which is a final analysis of zanubrutinib versus ibrutinib for relapsed refractory chronic lymphocytic leukemia patients. And second is a phase 2 trial of AVO, that is acalabrutinib, venetoclax, and obinutuzumab for patients with high-risk CLL. So we'll move on to Alpine study. Alpine study, the background is like we all know BTK inhibitors are first-line drugs in the management of CLL, and BTK is a key component of B-cell antigen receptor signaling pathway. Ibrutinib is first-generation BTK inhibitor. And most of us are using ibrutinib, and we are seeing in our clinical practice, treatment discontinuation rate is around 20%. Also, because it's a once in a day tablet, so there is a drop in maximum half inhibitory concentration of the drug. So there is an issue in efficacy of ibrutinib. Zanubrutinib, as we know, it's a second generation BTK inhibitor. It has high specificity for BTK, better exposure as compared to ibrutinib, as well as it has shown superior PFS compared to chemoimmunotherapy in untreated patients with CLL. and those without deletion 17p. So phase 3 alpine study, it does report the final efficacy and safety of zanubrutinib versus ibrutinib in the patients of relapsed refractory CLL after who have received more than one prior therapy. So this was a study design, and in that study design, this is a phase 3 trial, randomized patients with relapse refractory CLL who had received one or more than one prior systemic therapy with measurable lymphadenopathy and no prior exposure to BTK inhibitor, those who were not on any warfarin or any other vitamin K antagonist. So they were stratified with the help of age, geographical region, refractory status, deletion 17p or TP53 mutation status. Zanubrutinib was given as 160 milligram per oral BID, and ibrutinib was given as 420 milligram per oral OD. So the treatment was continued. It was a continued therapy trial, and the treatment was continued till some patient developed some form of progressive disease or unacceptable toxicity. And recently in NAGM, they have published their follow-up of 29.6 months, and it was presented in ASH also. So primary endpoint was non-inferiority or superiority of the drug, and secondary endpoints were incidence of side effects like atrial fibrillation, flutter, progression-free survival, duration of response, overall survival, and other parameters were also compared. So at 12 months, which was published in 2020 in JCO, we can see the curves were separating. PFS was had already started separating from the month of 6 to 9, and overall survival was also better at the end of 1 year in this alpine study, and the difference was evident in terms of superiority with zanubrutinib over ibrutinib in non-mutated as well as mutated 17p mutated patients. And now this was published on December 13, this month only, and they have published 29.6 month analysis of zanubrutinib versus ibrutinib, and the data is quite exciting. If we see the baseline characteristics, the median age was 67, and patients with more than 65 years of age were around 200 in each group. There was male predominance. ECOG was equal to 1 or more than 1 in 198 patients. Around 200 patients in both the groups. Majority of patients had 17p deletion, as well as patients with complex karyotypes were also included. IGHV mutated patients and unmutated patients were also there. So PFS at the end of 2 years is 78% with zanubrutinib, and it is 65% with ibrutinib. And overall response rate, you can see 75.7%. So zanubrutinib is clearly the winner in this race, and it has shown PFS benefit as against ibrutinib. If you see the subgroup analysis, age group wise, sex wise, or prior lines of therapy, as well as deletion 17p, IGHV, unmutated status, everywhere, our complex karyotype also, zanubrutinib is far better than ibrutinib. And what about 17p deleted patients? Yes, here also at 24 months, you can see the PFS of 72% versus 54% with ibrutinib. So zanubrutinib is a winner. Overall response rate is around 79.5%, which includes your CR, CRI, PR, PRI, and PR with L, that is partial remission with lymphocytosis, which is far better with, it's around, the difference is around 10%. So Zanu is better than Ibru. So overall survival also, you can see the curves are separating very nicely, and zanubrutinib is having overall survival benefit also with as compared to ibrutinib. Coming to the side effect profile. Side effect profile was interesting. Here, equal patients, like almost 318 patients developed any type of side effect. And in the Zanu group, as on ibrutinib group, 321 patients do develop those side effects. And severe side effects, if you see the percentage-wise data of severe side effects, severe adverse effect, it was 50% with ibrutinib and 42%. So not much difference. Dose reduction, yes. So with ibrutinib, we have seen dose reduction, and in this study also, the dose reduction with ibrutinib is 17%, while with Zanu it is 12.3%. Dose interruption was equivalent. It was 50% with Zanu, and it was 56% with ibrutinib. Treatment discontinuation is slightly more with the ibrutinib. 22% patients discontinued the treatment, and 15% patients in Zanu ibrutinib group did discontinue the treatment. Looking at other side effects like neutropenia, COVID-related infections, hypertension, URTI, diarrhea, and anemia, and arthralgia were more or less similar in both the groups. But exciting data is here, the cardiac adverse events, which we all are worried about. So cardiac adverse events were very few in Zanu ibrutinib group, around 21%. Serious cardiac events were very less. It was 1.9% and 7.7% in ibrutinib group. Ventricular extrasystoles were there. Atrial fibrillation, it was not reported in Zanu group, while it was reported in ibrutinib group. We all know atrial fibrillation is very common. So incidence of atrial fibrillation or flutter, any grade, it was around 5.2% in zanubrutinib, and it was 13.3% in ibrutinib group. So to conclude, Alpine study had shown zanubrutinib is having significant improved PFS and overall response rate compared to ibrutinib in patients with relapsed refractory CLN and small lymphocytic lymphoma. So PFS benefit has observed across all the subgroups and even among the patients with deletion 17p. Overall response rate was 86% with Zanu, and it was around 75% with ibrutinib. And it has shown favorable safety profile. Zanubrutinib is favorable, is having favorable safety profile as compared to ibrutinib. The rate of grade 3 or more adverse events were less. Fewer treatment discontinuations were there. It has a like better cardiac profile as compared to ibrutinib because rate of atrial fibrillation was less. So investigators have concluded that it shows PFS and overall response rate superiority of zanubrutinib over ibrutinib in the treatment of relapsed refractory CLL patients. So moving on to our second study, I'm going to discuss this study because in our practice, patients still they do ask for a fixed duration therapy. Whenever we, though BTK inhibitor is the first drug of choice, but there are some patients who cannot afford or who cannot take the treatment for long. So for those patients, I think this study can be a game changer. Also for high-risk patients, we do struggle in managing those patients of high-risk CLL, those 17p deleted patients who have 50% response rate with single agent BTK inhibitors. So this is a updated result of acalabrutinib, venetoclax, and obinutuzumab in patients with high-risk CLL. The study was having fixed duration of the treatment, and it was MRD-based study. So what is the background? We have seen combination of acala and obinutuzumab works beautifully in frontline setting of CLL, and management of patients with TP53 mutated disease still remains a challenging area in management of CLL. So we have seen triplet regimens like BTK inhibitor plus venetoclax and obinutuzumab is showing some promising efficacy in management of CLL. There are phase 2 trials which have shown it. IVO, that is ibrutinib plus vein plus obinutuzumab. Already data is published, while AVO in newly diagnosed patients also data is published, and zanubrutinib with obinutuzumab and vein is also coming up. So this study, AVO, acalabrutinib plus venetoclax plus obinutuzumab, was planned for the patients who were having TP53 mutated disease. So this is a study design. In this study, patients who were more than 18 years of age, previously untreated CLL patients, high-risk CLL patients, PLL patients, as well as those who were having TP53 mutated patients and high risk from cytogenetic point of view, those patients were included in the study. The study design is slightly complicated. In cycle 1, they have used only acalabrutinib, and from cycle 2, obinutuzumab was added till cycle 7. That means 6 cycles of obinutuzumab were given. Venetoclax was introduced from cycle 4, and standard ramp-up dosing was done from 20 milligram to 400 milligram. And after end of 16 cycles, bone marrow as well as peripheral blood MRD was done. Those patients who developed who achieved bone marrow MRD negative status or peripheral blood negative status were off therapy, and those had positive MRD, they did continue the therapy till 25th cycle. Additional 9 cycles were given, only acal and vein. Obinitu was there from cycle 2 to cycle 6, cycle 7. So after 25 cycle also MRD analysis was done, and those who developed MRD negative status, they were off therapy, and those who had MRD positive status or those who developed again MRD positive status were restarted on acal plus vein. Most of those patients were receiving mandatory prophylaxis for ECP and HSV. So primary endpoint was CR rate with undetectable MRD in bone marrow after 15 cycles. Secondary endpoint included overall response rate, PFS, AFS, and remission duration. So basic characteristics, if we see, total number of patients were 68, median age was 63, rise stage 3, 4, 32 patients had a rise stage 3 and 4, 23 patients were having bulky lymphadenopathy. Average WBC count was 99, hemoglobin was 11, and platelet count was 1,46,000. TP53 mutated patients were there. Around 41 patients had either deletion 17p or TP53 mutation. IGHV mutated patients were around 15, and 50 patients had unmutated status. Complex karyotype, 16 of those 61 patients had complex karyotype, and 10 patients had notch mutation. So efficacy at cycle 16, at the end of cycle 16, MRD detection was done, and CR rate with undetectable MRD in bone marrow at cycle 16 was done, and which has shown most of the patients, at 43% of patients could achieve that. And TP53 altered patients, around 45% of TP53 mutated patients could achieve the MRD negativity at the end of 16 cycles. So MRD analysis at the cycle 16 from peripheral blood and from bone marrow. You can see around 80 to 90% of patients could achieve undetectable MRD in both the groups, and with the help of peripheral blood also and with the help of bone marrow also, they could achieve MRD negativity at the end of 16 cycle only. And what about cycle 25? Those who were off treatment and then they develop MRD positivity, those patients were restarted on acal vein, and those patients who did not achieve MRD negativity, they were continued. Almost 19 patients could discontinue the treatment. Out of 19 patients from cycle 16, out of those 19 patients, 3 patients developed progression of disease. While at the end of 25 cycles, if you see the data, CR rate was around 44% and PR rate was around 51%. And MRD negativity was in the range of 80 to 90%. What about safety signals? So safety wise, if you see, most of the side effects are headache, fatigue, bruising, nausea, hypocalcemia, diarrhea, infection, rise in creatinine, altered LFTs, and arthralgia were there. And any other side effects? So COVID-19 infection, atrial fibrillation was there, but in only 3 patients, and grade 3 COVID infections were there in 5.8% of patients. Febrile neutropenia was not reported. So survival wise, if you see, disease progression occurred in 4 patients. 1 patient had a CLL progression and he was 17p deleted. 2 patients transformed to Hodgkin's lymphoma, and 1 patient transformed to DLBCL. 1 patient died due to COVID-19 pneumonia. At the end of 35 months, 98.5% of patients are alive and 92.6% patients are progression free. So frontline AVO in high-risk CLL. To conclude, in this phase 2 study with a cohort of untreated patients with CLL enriched for high-risk disease, combination of ACAL plus VEN plus OB do yield high responses. At cycle 16, bone marrow undetectable MRD was seen in 83% of patients with TP53 altered disease. Also, at the end of 35 months, 93% of patients were progression free. And of 41 patients with TP53 alteration, 1 patient did experience a disease progression, but rest of the other patients were disease free. So to conclude, treatment with ACAL, VEN, and OB was well tolerated. Cardiac and infectious side effects were uncommon. It is being evaluated in phase 3 trial ACL 311 or amplified trial, and we'll soon get the results of those trial. And we can conclude that MRD guided and fixed duration treatment with ACAL plus VEN plus obinutuzumab combination can be tried in CLL, particularly in high risk disease like 17p deleted patients. We can try this, and we can give them the hope of disease free status. Thank you.
Very delightful and understandable talk given on CLL by Dr. Nilesh. Thank you so much for such a nice talk, Doctor.
Thank you.
With this, we'll move on to our take-home message. And for that, I would like to invite Dr. Nitin Sood. He's Director in Hemato-Oncology and Bone Marrow Transplant, Medical and Hemato-Oncology, Cancer Institute, Gurugram. Thank you, and over to you, sir.
Yeah, hi. Thank you, Priyanshi. And please convey my thanks to Dr. Ved for inviting me for this session. I don't have any slides, so I want to thank all my previous speakers to make my job of take-home message easier. I'm just going to there were several studies in leukemia, myeloma, and lymphomas which were presented as part of the general sessions and part of the late breaking abstracts. So I've picked a few to say that these are the ones that we need to watch the space to see if these are the ones that are going to come into either standard of care, or these are the ones that are interesting. So the first one I picked was already presented, but I'll just give it a summary. Is about magrolimab with venetoclax and azacitidine in older and unfit patients with newly diagnosed or relapsed refractory acute myeloid leukemia. And as we all know, despite frontline responses of 65 to 70% with the aza-ven combination, which has become standard of care, only about a third of patients remain alive at 3+ years, which means this is a great area of need. And then patients who have TP53 mutation, which is the highest possible risk with AML, continue to have a poor outcome with median overall survival of only 5 to 6 months. Similarly, relapsed refractory ones have, again, a median overall survival of 6 months or so. And adding a hypomethylating agent when combination adding magrolimab to this combination, and magrolimab is an anti-CD47 antibody that blocks the don't eat me signal on the leukemia cells, is in theory going to do very well. And so this study was designed as phase 1b2 clinical trial to evaluate this triplet combination. And this combination has been associated with a high rates of marrow response and remission in not only newly diagnosed and older patients with MDS and AML, but in particular, it's shown promise in the TP53 mutated patients. So this combination needs to be looked at in more detail and to see if this can become the next standard of care in older relapsed refractory and TP53 mutated AMLs. So the next one I picked was the Comet 001 trial, which was also interested and looked at ziftomenib in patients with relapsed refractory AML. As we know that menin inhibitors in clinical trials have been quite exciting, and these drugs appear to have marked activity in the relapsed refractory AML space, especially the ones who have NPM1 or KMT2A alterations. As with most of these targeted agents, especially IDH1, IDH2 type drugs, differentiation syndrome can be seen as an adverse event and a drug-related adverse event, which we need to be careful about and to monitor. So ziftomenib is the drug that we need to watch out for. Now, the third abstract that I picked up was a long-term follow-up of VIAL-A study. And this was a phase 3 trial of venetoclax azacitidine combination in patients with untreated AML who are ineligible for intensive chemotherapy, meaning they are eligible for the hypomethylating agent combination. And so an abstract was presented to look at VIAL-A long-term follow-up, which demonstrated that there is an overall sustained overall survival benefit with ven-aza combination in AML patients who are not eligible for intensive chemotherapy. But obviously, this was compared to placebo plus azacitidine, which means now aza-ven, we have more confidence in aza-ven as a standard of care. And this long-term follow-up analysis confirms the long-term survival benefit that this combination can give to our patients with no additional safety findings, which is the more important thing. So enough about AML. I brought a couple of ALL studies as well. And GMAL Initial 1 study looked at inotuzumab ozogomycin induction followed by chemotherapy in de novo BALLs were newly diagnosed. So inotuzumab, as we all know, is now approved for the CD22 positive relapsed ALLs. But as progression happens, inotuzumab is going to come into the newly diagnosed ALL space as well. And this is what was looked at in this study. And treatment of BALL in older patients is quite challenging anyways. We end up giving a bit of steroid, a bit of incretine, and maybe targeted therapy. So traditional induction carries a lot of mortality. It does not lead to long-term remissions, which is why the thought of incorporating the anti-CD22 antibody drug conjugate inotuzumab into frontline therapy is a promising strategy. And the emerging data from this study suggests that high levels of efficacy and impressive survival in patients who are older than 55 years of age, by definition, not eligible for intensive induction. So again, that's a space we need to watch out for because these drugs are going to come very quickly into frontline induction. And not only induction, the other study that I bought was the ECOG Akron E1910 study, which looked at blinatumomab as consolidation. So I know as induction and blina as consolidation now in newly diagnosed adult BALL who are MRD negative post-remission and post-induction. And blina, when added to consolidation chemotherapy, resulted in significant overall survival improvement in these patients with newly diagnosed BALL who were MRD negative after intensive chemotherapy. And more importantly, there were no new safety signals. We have to remember that these bispecific antibodies can have their own type of complications that we need to be aware of. But when these are used in minimal residual disease setting, there are not many new safety signals, which brings in the confidence associated with these ones. So these data suggest that addition of Blina to consolidation chemo represents a new standard of care. And that's a strong statement for newly diagnosed BALL who are 30 to 70 years of age. So we are going to see change in this space. Now, enough about acute leukemias. The other one I brought was about CML. And there were quite a few presented in CML, but this one struck my eye because this was looking at low-dose dasatinib as frontline therapy in newly diagnosed CMLs. As we know, sometimes patients find it really hard to tolerate the standard 100 milligram dasatinib dose. So this study looked at dasatinib at a 50 milligram daily dose. And this was a median follow-up of 5 years, so not a small time. And at the end of 5 years, this 50 milligram dose continues to be effective and safe in almost 83 patients with newly diagnosed chronic phase CML. And the 5-year event-free and overall survival rates were very high at 97 and 98% respectively. So these data support that we can still use low-dose dasatinib therapy as a reasonable approach in newly diagnosed CML, especially in patients who are unable to tolerate the higher dose. So now coming to CLL, SLL space, in the relapsed refractory CLL, SLL, zanubrutinib was compared to ibrutinib. So this is possibly the first trial comparing, actually not the first trial, but trial comparing two BTK inhibitors head to head. And this was a final analysis from the phase 3 Alpine study. And we've looked at Alpine study in the past as well, but the final analysis shows that there is improved progression-free survival, and this was just presented. And safety with zanubrutinib compared with ibrutinib in patients with relapsed refractory CLL, and is the first demonstration that one BTK inhibitor, especially the more selective ones, which is both acalabrutinib and zanubrutinib, is superior to the other one. So zanubrutinib being coming out as the better one with lesser side effects and improved progression-free survival. So this is possibly going to change the standard of care in the coming few years. Coming to myeloma, and this ASH was particularly outstanding because there was a lot of data on bispecific antibodies and a lot of data on CAR T cells. And so I brought the KarMMa-2 abstract, and these was results from a cohort of 2A of a multicentric phase 2 trial, which evaluated efficacy and safety of idacaptogene vicleucel. So ida-cel for short, and this is a CAR T cell therapy in myeloma. It's already approved. And this study looked at 37 patients who experienced early relapse, so the very high risk group in frontline induction after transplant and Len-containing maintenance. The results demonstrate that even in this cohort, the very highest of risk, there is potential benefit of use of CAR T. So I think this is an area that we need to look out for because CAR T cells are coming earlier into lines of therapy. And as long as there is no bulk or no bulky disease to start with, most of these cellular therapies in this space are going to do well. So finally, talking about MDS MPNs, the momentum study was also presented, and I also wanted to just update the results of this phase 3 trial. And momelotinib versus danazol for patients with anemic myelofibrosis who were previously treated with a JAK2 inhibitor. So as you know, JAK2 inhibitor ruxolitinib is available in this country, and we are constantly looking out for options in patients who failed this JAK2 inhibitor. And our center has many patients who've already gone 4 years, 5 years with the JAK2 inhibitors. So momelotinib is going to be an interesting drug in the coming future. And the previous results showed that momelotinib, which is a JAK1, 2, and ACVR1 inhibitor, is associated with improved symptom anemia and spleen size control versus danazol. So remember this, there's no two JAK2 inhibitor comparisons here. Pacritinib is the other JAK2 inhibitor now, which is approved. But momelotinib is going to be interesting to watch. And finally, a couple of abstracts from the non-malignant hematological disorders. And ADVANCE 4 looked at a drug called F-gartigomid, and it's a complex name, but this is a new class of drugs that might be useful in chronic ITP. And as we know, there are certain chronic ITPs that don't respond to any forms of therapy. And we have access to L-Trombopag and Romiplastim, and there is splenectomy and IVIG, but they just don't seem to respond. So this is a new class, the first drug in this new class. And it's a human IgG1 Fc fragment, which competitively binds to the FcRn to prevent the recycling of IgG. And by definition, if you prevent the recycling of IgG, the pathogenic IgG autoantibodies get reduced, and the fall of platelets is less. So if you compare this drug to placebo, then it led to early and sustainable platelet recovery, including more weeks with platelet levels above 50,000, which is our relative aim in ITP. And the last one was PNH, and we have no drugs for PNH, and Soliris or eculizumab and rivaroxaban have been around the world for quite some time. But now there is a tablet called iptacopan. It's a proximal complement inhibitor of factor B. And it was actually tested against patients who were already on eculizumab or ravulizumab and remain or continue to have a less than 10 hemoglobin and a high LDH despite these two drugs being on board. And both these drugs, what they do is prevent intravascular hemolysis. They don't prevent extravascular hemolysis. And iptacopan potentially will also prevent extravascular hemolysis, which makes it a superior drug and easier to deliver drug because it's a tablet. So iptacopan is the one that we need to look out for in the non-malignant space. So with that, without wasting any more time, I think that's my take-home messages. If anybody has any questions for me or any of the other speakers, they're free to ask. With that, I'll pass it back to Priyanshi.
With this, I thank all the faculties for joining with us today. Thank you, Dr. Suman. Thank you, Dr. Anita, Dr. Nilesh, Dr. Deba, Dr. Rakesh, Dr. Nitin, Dr. Vikas. Thank you to all. Last but not the least, thank you, Dr. Ved, for conducting a great masterclass. And thanks to all the audience who have joined with us as well. Thank you so much.
Thank you.
A special thanks to Dr. Nitin, sir, for summarizing 7 presentations. I think so, 6 or 7, Priyanshi?
7 presentations.
7 presentations. That's a Herculean task. And thanks to all eminent doctors who were the faculty. And a core thanks from my heart, and wish you all a very good, prosperous 2023, and Merry Christmas.
Thank you, Dr. Nitin sir. You have added non-malignant hematology also. That was needed. Thank you, sir.
Good night.
Thank you.
Okay, good night. Bye-bye.
Thank you, sir. Bye. Priyanshi.
Hello.